Joining me on this episode of the Anthro Education Podcast is Dr. Eric Cobb. I've wanted to do this episode for a long time. If you're not familiar with who Dr. Cobb is, hopefully this show just opens your eyes to one of the Goliaths of what I believe to be our profession. So who is Eric Cobb? Well, he is one of the world's leading experts in harnessing the power of the neurology of movement to create extraordinary change in the human body. He is the creator of Z-Health, which I was introduced to over a decade ago, which has actually been around for almost over 20 years now, which has become an expansive online and in-person education platform for everything, functional neurology, neuroanatomy, applied neuroscience. And we dive into all of that on this show. So without further ado, Dr. Eric Cobb. All right, so you just heard the long-winded, fantastic intro to my guest today, which is Dr. Eric Cobb, and I'll let him give a little bit of a origin story here in a second, but I have to first precede that with, I still don't honestly know how I stumbled upon Z-Health because I've been in practice for almost a decade now, and I graduated in 2013. Right when I got out of practice, something popped up, and I think you'll appreciate what I'm about ready to say. I know Z-Health was rolling, but when I got like the Vision Gym versus what it is now and like the online platform, it's literally like going from 2D to 3D from the way it's offered. So a couple things here. First of all, I appreciate what you do and have done and continue to do. And thank you for kind of opening my eyes, which is a fantastic pun, if anybody understands what we're about ready to talk about, to the world of, and maybe, hopefully I'm not giving this misnomer of functional neurology from your approach or your team's approach. So my first question to you after all of that talk is, what is your origin story? Like, how did you get into healthcare? How did you get to where you are today?
I've been asked this many times. I try and keep the story relatively consistent, so we'll see how it goes. I grew up as an athlete, and in addition to being an athlete coming from kind of an athletic family, I also had all these kind of weird birth defects we didn't know anything about. I was born in 1970, and my mom had taken some medication for morning sickness at that time, long before we knew some of the ramifications. So I spent the first few years of my life in the hospital off and on with GI disturbances, pretty severe asthma, etc. So I always tell people I had this weird dichotomy of I was pretty athletic on one side, but I also had a lot of illness. And as a result of that, a lot of pain issues. So by the time I was in high school, thinking about going to college, I was debating what I wanted to do. And I thought, well, I could go to med school, I could do this, but I really wanted something that was much more movement focused. I had friends that were orthopedists and of our family. I spent some time with them, got to know a little bit more about the medical side, and figured that that really wasn't for me. I was much more interested in movement and therapy. So decided to go to chiropractic college at that time after I finished my bachelor's. And it was for me, it was a really unique experience. It was, I thought the academics were actually very high. They were very interesting. I loved anatomy. I loved neurology. I got very interested in neurology when I was in school, as one of our neurophysiology professor had studied extensively with some of the originators of kind of old school pain theories. And so a lot of our neurophysiology was focused on pain modulation. So I found that very intriguing, but I didn't find a lot of, at that time, I think because I was quite young in the educational process, I didn't really understand it from a practical perspective. Mm-hmm. So eventually, after I got out of school, went into practice, I had, again, this weird dichotomy of I had a bunch of high-level athletes as patients, and I also had a lot of chronic pain patients. And I think that was just based on the general approach that I took. And it was only 3 or 4 years, I think, into practice, I started getting very frustrated. I was using a lot of I'll call them traditional modalities, although obviously, I don't know if we can say anything's traditional. It's really about application.
Just for reference, when was this? So when did you graduate from Chiro school?
95.
Okay, so just thinking what was available from like techniques, modalities, what was very prevalent, what were like your main tools?
So I went to school out in Portland, Oregon, at Western States. So we primarily had, from a chiropractic perspective, it was primarily diversified technique, and I had some flexion extension tables. I had taken courses with McKinsey. At that time, actually, when I was in school, two of my professors had been to the Czech Republic, studied with Levitt and Yanda. So we also had incorporated a lot of, at that time, what was considered proprioceptive rehabilitation. And then obviously a lot of physical therapy modalities. So I felt like it was a pretty good blend of musculoskeletal um, approaches as we knew them at that time. But as you go through the course of a clinical career, you collect patients that teach you things, right? That's part of the process of being in practice. And I had this very interesting experience. I think I'd been in practice a couple of years, and I had a lady that was coming to see me for chronic neck pain. I'd been working with her. I think I'd seen her 3 or 4 times, and we were making a little bit of progress. But when you're dealing with chronic pain issues, particularly from a hands-on perspective, a lot of times we're like, well, we don't really know how long this is going to take. And at that time, with our relatively limited understanding of pain from a brain perspective, um, again, I was doing the best stuff that I knew to do. She was showing up, which was her job. And so I had seen her on a Friday, and I had scheduled her for a week out. And I think, like I said, I think it was going to be her 4th or 5th visit. And she came in the following week, and I could tell immediately. I saw her coming in from the waiting room, and I was like, "Oh man, this is awesome! She looks really good. You know, she's more free. Her neck looks good. She doesn't look like she's in pain." And I sat her down, and I said, "How you doing?" She's like, "I'm great. My neck feels great." And I immediately launched into what I call the practice management spiel. Of, well, you know, it's good after 3 or 4 treatments, things start to get better. The brain's understanding what we're, you know, whatever. And she looked at me and she's like, I don't think that's what it was. I'm like, what do you mean? And she's like, well, it's been like 5 years since I've been to the optometrist, and I had an appointment early last week, and my prescription was really off. They changed my prescription. My neck has felt great ever since. And I was like, well, that's great. And, you know, continued on and with that day. But it really got me thinking. For whatever reason, it just struck a chord with me that maybe there are far more systems involved in pain than I recognize. And I guess that was probably 1997, 98. And that has coalesced with, again, all my traditional education, the work out of Prague, and a lot of other stuff for now. That's 23, 24 years of trying to understand neurology at a much, I think, more extensive level, and how all the systems of the body interact to create movement, create pain, create athleticism. And so that, after, I don't know, I think I did a lot of personal work and research on it for 6 or 7 years, and then launched obviously our company now, which is a continuing ed company that has been in a continual state of evolution since that time. So that's a little bit of the origin story, I guess, if you want to call it that.
Well, and for anybody listening, because most of the listeners, as much as I hate to say it, are just nerds like us, right? PT, Chiro, you know, whoever. I might get some flyers that are like, what are they talking about? And they might turn it off in 15 minutes. But so even if we're speaking to our profession, what's the elevator pitch of the different approach for Z-Health? Because I've used a lot of what you've taught for the better part of a decade now. And honestly, it's been one of those, like, for me, it's a practice in application, right? It's one thing to, I would say, you understand through application, but it's one thing to learn this stuff. It's a totally different game to plug this into practice, especially when you had an existing practice model, which same thing, a lot of DNS, MDT, adjusting, soft tissue techniques. Thought I was playing at a high level, and I was like, why was I missing this whole piece? Or so what do you, if you had to explain it to a PT or chiro that had never, heard of what we're talking about, and a lot of students haven't, like, I'll show something, they're like, what are you doing? Like, where'd you learn that? So what's the 30-second? And then maybe we'll dive into that a little bit further.
Oh Lord, you asked this is still something after 20 plus years. I don't have a good 30-second elevator pitch.
Your business coach is just shaming you every day, right? Like, gotta
Absolutely.
get that
Yeah.
down.
I tell people I'm a clinician, I'm not a marketing guy. The basic idea, obviously, for me is we just call it applied neuroscience. And the simplified concept here is that movement is a symphony. Our traditional education focuses on one section of instruments, right? We have a musculoskeletal section, maybe we're in the peripheral nerves. We studied shot clock, neurodynamics, whatever. The bigger issue is that when you dive into neurology, you have to understand that there are multiple systems involved in motor control, moving efficiently and safely through the environment. So our approach has been, let's look at every neural component, so the visual system, the vestibular system, and look at that from a functional perspective so that we can understand that potentially the pain syndromes we're dealing with, the movement dysfunction we're dealing with, is being driven by higher order processing deficits. That higher order processing deficit could be something like I have maybe convergence problems with the visual system. And once you start understanding the relatively deep neurology behind that, all of a sudden you start to figure out ways to blend what you already know with kind of this emerging neuroscience approach, I think, to create faster results for people. So that's probably a minute and a half that means nothing to people still.
Pretty good. Well, and I really want to dive into this because one of my goals for this podcast is to learn as much as I can from you while I have you on here, but to help elucidate how this fits into a framework, right? Because and I want to hear your opinion on this. It doesn't replace anything. I think it's in addition to. So my two questions would be, how does it fit into the framework? And then if we had to approach things from a prioritization, right? What we would be doing first, is this just, well, that's an n=1 and we have to approach it from the exam and what the patient's telling us? Or are you like, no, this actually fits higher up because you can knock out other things?
Okay. Those are some relatively deep questions. So let's kind of start with, does it replace things? The answer is both no and yes. From a experiential perspective, what I can tell you is that understanding neurology, understanding how to do a really competent neurologic exam from a functional perspective can save you a tremendous amount of time in practice. Because I think what is often missing for a lot of us is a very deep understanding, first and foremost, of current pain neuroscience. Now, that is improving, I think, in the current educational environment. But while many people have heard of the pain neuromatrix theory or biopsychosocial models, the practical implementation of that, I think, is still very difficult for people, because they hear, okay, biopsychosocial, great, I'm the bio. All right. Or I've heard of the pain neuromatrix, but I'm not a brain person. So what do I care if the thalamus or whatever is being impacted? So the first thing I try to get across to practitioners is you are always practicing neurology, whether you know it or not. Like you're either doing it accidentally or you're doing it on purpose. Most of us would prefer for our physicians, our therapists, to do things to us on purpose as opposed to by accident. So whenever you understand, your basic wiring diagrams, you understand how things work in the central nervous system, I think it begins to alter the types of assessments and examinations that you do. I think it alters your interpretation of them to more quickly hone in on potential threats. I think from a practitioner's perspective, one of the kind of key teaching points to start with, or key understanding components, is understanding pain from, like I said, kind of the modern, our modern view of it based on neurology. So if people are not familiar with the pain neuromatrix, you can look it up. It's an evolution of Melzack and Wall's gait control theory from 1965. They actually published on the pain neuromatrix in 99. Since then it has exploded with the advent of functional MRI. We know so much more. But the basic summary is this: pain is a construct of the brain based off its relative feelings of safety and danger. I mean, I can't make it any more plain than that. So often our classical education models say if someone has knee pain, if someone has low back pain, we need to identify the pain generator. Well, the pain generator is the brain. So that doesn't mean that nociception in the periphery isn't important or mechanical deficits in the periphery are not important, because those are they're playing a part. They're part of an equation that's occurring in the brain. The brain is saying, hey, I'm taking in this data from my eyes, this data from my vestibular system, my proprioceptive system, whatever. It's trying to merge all that data. And based off its merging and interpretation of that data, it's then determining if the organism is currently experiencing excessive levels of threat. If I'm experiencing excessive levels of threat, that means that I need to change something, right? It's now become dangerous for me to stay in this current state, whether that's this current environment, whether it's this current movement pattern. So when you start to, I think, view it from that perspective, it becomes incumbent upon us to understand how many threats potentially can arise and can we identify them. One of the things I love most about this from a replacement perspective in terms of what happens for professionals is often I think when you understand this approach, you understand, like I said, the neurology behind it, the pain science behind it. What winds up happening is you find it almost easier, I guess I'll say it that way, to manipulate inputs into the body and brain to reduce threat. So, like I said, from a replacement perspective, if you're already good at something, it should never replace that, but it should enhance it and allow you to use it much more elegantly. From a personal perspective, the more I've learned, the more I've implemented this approach, I find that I do, in many cases, far less with people, but far more targeted. So if and basically one of the things we often forget is therapy is comes at a metabolic cost. No matter what we're doing, we are creating inputs into a system. We're asking it to change. We're asking it to modify its behavior, modify its function, which costs energy. When you increase metabolic cost, that increase metabolic cost for the brain. So if we can make significant changes for people with lower metabolic cost, it often makes the entire therapy process, I think, easier for them to participate in. So that's kind of my first take on the replacement factor. Like I said, it's a yes and a no. If you're great at something, it should never replace that. But hopefully this will, again, help you make it more targeted. So that was question number one.
Yeah. Well, let's jump off on a tangent real quick. Is there any specific example? Because you said that you were introduced to, the Prague School and MDT, and which I think at the time from Western states, I think that was pretty far ahead because, we're still not seeing MDT and things like that in standard curriculum in most schools. Is there any kind of methodology or ideology that really, it's almost like you pulled the veil back on that methodology by diving into what you've learned, which I would assume is a yes, because like you said, it's just neurology. But where you're like, oh, I was doing this, but now I understand far better why that was working like it did. Is there anything specific that will help elucidate that for people?
Yeah, I guess my general answer is yes. If you look at a lot of I guess what would be considered more current musculoskeletal approaches that are linked to movement practices, I think once you understand something like the vestibular system in depth, you will see that we are providing what we call stacked stimulus all the time. So let me kind of make this somewhat understandable. Whenever we are dealing with particularly any kind of chronic movement or pain dysfunction, we are dealing with someone that's already probably gone through relatively extensive plastic changes in the central nervous system, right? They've had changes in the motor cortex, premotor cortex, somatosensory cortex, whatever. So a part of rehabilitation at this point, means we have to consider, are we creating sufficient and appropriate stimulus to alter that plastic change to a more functional or more useful pattern for them. So whenever you start to look at any therapy, it's, I think, very important to understand what you're isolating and what you are integrating. So whenever we start talking about the vestibular system, when I went through school, obviously we studied the vestibular system, but I realized 20 years ago I really knew nothing about it other than how to do a Apley's maneuver and how to refer them to someone else. Hey, if it's not cervicogenic dizziness, then I don't know what to do. And that's very unfortunate, because if you think about the vestibular system and what it does, and if you understand the canals, you understand the otoliths, when you start to look at many movement approaches that are incorporating, let's say, vertical displacements, lateral displacements, you start to recognize that maybe many of the changes we're seeing in extensor tone or changes in muscular function may have less to do with the exercises we're prescribing or the therapy we're doing, and more to do with the fact that we are stimulating very specific portions of the vestibular system, dependent upon the movement that we're doing, the eye positions we're having them hold. The Prague school was very interesting, obviously, because they've used eye movements and eye positions for a very long time to facilitate, cervical motion or spinal motion or whatever. So that was always interesting to me. Now that we know much more about how all these systems integrate and where they're controlled centrally, it also very much helps, I think, explain some of the things that we see. In terms of explaining a given approach, actually, I think applied neuroscience explains all approaches at some level, where you can look at it and go, okay, well, I was working on this client's ankle. What was I doing? Well, I was doing massage. I was doing some mobilization. And if you have gone through your mechanoreceptors, you understand you have, two primary afferent pathways from the periphery into the spinal cord. Where do those go? Well, they're going to decussate here. If I understand all of that, all of a sudden, everything that I do with a client, I think, has more intent behind it. Mm-hmm. It also, I think, helps explain and helps practitioners explore options that maybe they were missing previously. So, for instance, whenever I'm teaching a neuro exam, whenever we talk about, are you doing sharp, dull, vibration, or, whatever, warm, cool, it's not because that's the textbook way to do a neuro exam. It's, can you explain what systems you're impacting? What receptors are you impacting? Because when we understand things from this applied neuroscience perspective and a pain neuromatrix perspective, a lack of input from a specific receptor type, a specific afferent pathway, that's a threat, because our brain is relying upon that information to feel safe, right? If I have a right side deficit in my ability to feel sharp, dull, then I'm probably going to be much less likely to want to move through an environment where I'm going to run into things because my predictive capacity is now degraded because I'm lacking that sensation. Most people wouldn't think that would be enough to drive pain, but remember, pain is a opinion of the brain based off this total sum of threat that we're experiencing. So, like I said, I think when you can view it from that perspective, almost all physical therapy approaches, manual therapy approaches, and movement approaches, I think, can be understood with a greater degree of complexity and a greater degree of accuracy. And what's beautiful about that is it then allows you to say, is it really the movement? Is it the head position? Is it the eye position? Is it the combination of the three that's creating the benefit for the client? And that, like I said, just being able to differentiate that has huge value.
Today's episode of the Anthro Education Podcast is brought to you by The Age of Movement by yours truly. Subtitle, Time Keeps on Moving and So Should You. The Age of Movement it's a short read. It's aimed at Gen Pop, and it is a look at the health conundrum we're in and what aspect or role movement plays in that. The middle of the book is a guide of movement from utero all the way to death, broken into sections of what's expected, what's normal, and some tips on what you can do to improve your movement and overall health. And then the last portion is just my opinion on where we're going and what our relationship with movement needs to be to have better outcomes in the future. So Again, The Age of Movement, available on Amazon, also available on Audible. Go check it out. And I think we've mentioned the Prague School a couple of times. It's always interesting. I mean, Pavel Kolaj is a neurologist, right? So that it's this we would say a movement-based practice, but it's a movement-based practice based on neurology at a very high level. And I think that leads into my next question. I may be misquoting you, but I'm pretty sure I've heard you say something like this before. I would say it's kind of like looking out into the ocean when you dive into neurology in general, and then functional neurology, like you said, is applying that to what we're trying to do with conservative musculoskeletal care. How we understand very little about the neurologic system of a human, right? And this is the misquote, but I think I've heard you say something like we understand like 1% of neurology. So then and I know how I interpret that, but like, how do you take that and say, well, I'm trying to understand all this, then apply it to a human? And I can very easily see how somebody's like, well, if you only understand 1%, well, how are you actually doing anything? So how do you kind of combat that, like back and forth, like, well, low understanding of this complex system, but I still have massive effect based on input output?
Sure. So I think we're better than 1% at this point.
That was a decade ago.
Yeah. What I can say is that really the last 25 to 27 years has revolutionized neurology. I mean, across the world. The advent of new technology has made things much more clear than they used to be. The quote that used to be popular was that we've learned more since 1995 than in the entire history of humankind about how the brain functions, and about 80% or 90% of what we thought we knew we were wrong about. So that's kind of the starting point. Now, that doesn't mean that we don't actually have a lot of accurate data at this point with basic functions, right? If you want to talk about the cranial nerve exams, we pretty much know how those work. When we talk about convergence eye movements, divergent eye movements, saccades, smooth pursuits, we have a pretty clear picture now, particularly of the visual system, the vestibular system is growing, of at least the fundamental components, how they work and how they integrate with the rest of the body. So while it is complex, I always tell people it's complex, but it's understandable, right? It's not the black box that it used to be. Whenever whenever I was in school, neurology was very much to some degree a black box, where we kind of knew, hey, if someone has a lobotomy, if someone has a stroke in this area, this is going to be the clinical result of that. But the information on kind of neurotransmitter interactions, the network approach that is now being discussed in much more detail, a lot of that didn't really exist. We were very much still stuck on Brodmann's areas, right? This part of the brain does X, this part of the brain does Y. And we now know that that's really not how it works. It is this vast, complex, interconnected series of modules that alter behavior based off what's occurring in the environment. So while, like I said, we have a lot of the basic scheme down, we know a lot about basic functions, there's still a tremendous amount to discover, which is one of the reasons I still love the field. I find it very interesting and very intriguing. Now, with that said, let me kind of give you an example of, I guess, just anatomy, right? I had one of my professors when I was in school. He was not a lot of fun as a professor. He was very intense, very rough on us. But one of his favorite sayings was, everything we do is applied anatomy. And that stuck with me from the first time I heard it. So I alter it and go, everything we do is applied neuroanatomy. But I think it still holds true. And I think it's one of the things that if we could get across to more students, I think they would be a little bit more diligent in, you have to know your anatomy. Because everything that we're doing is trying to understand what's occurring either locally or systemically. So as an example, let's talk about eye movement. So obviously we have convergent eye movements, right? Eyes are moving together. Most people that have worked with convergence insufficiency or worked with behavioral optometrists, this is one of the most classic, evaluations that we'll ever have people do. So the question then becomes, well, what does that do in movement, right? why would that matter? Why would my ability to accurately converge my eyes change anything? So when you actually then look at the cranial nerves, we have cranial nerve 3, cranial nerve 4, both are going to be involved in controlling muscles convergence. When you look at the nuclei, those both reside in the mesencephalon or midbrain. When you look at the midbrain in studies related to the gait cycle, as well as other movements, the midbrain is really well associated with increased flexor tone in the body. So if I have someone that's struggling with shoulder flexion or forward bending, it's entirely possible that if I do a good cranial nerve exam and I look at their convergence capacity, I'll probably find some deficits. Even if I don't find deficits, I may be able to encourage increased flexor tone by having them do some basic convergence exercises for the eyes. So that's, a starting point. If you then take that a step further, we can then start to look at the direction of convergence and the speed of convergence. So then, at that point, we then have to move out to some other areas of the brain. We have in the premotor cortex, we have an eye field that helps drive convergence to the contralateral side of the body. So let's say, and this is basically my job, is to go, what's this weird neurology? How does this practically apply? So if I now say, okay, if I had a client come in and they have right shoulder pain, and that shoulder pain is specifically with some flexion abduction movement. In other words, they're trying to reach up, they can't reach up to get their glass out of the cupboard with their right arm. We know that our basic neural wiring pattern is going to be, that's going to be my left cortex. It's going to be driving right side motor activity. So I'm probably needing to do something to target left cortical activity. So in addition to sensory work and motor work, could I use the eyes? Well, of course I could use the eyes. So if I understand that the left premotor cortex drives convergence to the right, I can then set up a little vision exercise where they're having to rapidly converge to the right side. That's going to increase left premotor activity. And about 30% of what the premotor cortex does is control that shoulder. So that's why anatomy is important. It's not knowing it so you can talk about it with other clinicians and be cool at the dinner party. It really is, for me, can I create, based off pure anatomy, an intelligently designed exercise to stimulate specific areas of the brain to hopefully improve function? Because when I think about rehabbing someone's right shoulder, it's often far more palatable for a patient to do 5 to 10 reps of a vision exercise than 30 minutes of rehab tubing work or whatever I'm wanting them to do. So for me, it's really about the speed of the process, and can I, again, collect a grouping of things that are anatomically intelligent to create the changes that we're looking for.
But I love that you keep just going back to, you've built on the applied anatomy quote from your professor, but like I just had Dr. Kathy Dooley on, who was my neuroanatomy professor in school, which I was very lucky because she was there for a super short time. But right. Now her whole thing is applied anatomy, right? That's the whole thing she's teaching, because she was like, there was no connection. We learned anatomy, we learned neurology, we learned neuroanatomy, but there was no application, which then you lose the kind of the I don't know, the steam under your ass of like, well, why is this important? Right? You're told it's important, but you don't understand the integration to actual treatment, which is hard because there's a bunch of other steps in between there and getting to treat a patient. I get that. Right. But I love that you went through that example, because you can try to distill this down for a patient really easy. And I always just find myself saying, if you turn your head this way, this eye has to go in. Does it make sense that may, restrict something if you can't do that? They typically understand that. But I could also see a Chiro PT student just listening to this conversation and going, dear God, but this is the time. This is what I tell students all the time. Like, you need to understand things so you can understand why things are happening, because you can be taught things, right? Like Gray Cook may be teaching a diagonal half kneeling, rotational pattern, but I guarantee you he understands a lot of what you just said. And it's like 5 layers deep, but he's like, oh yeah, we're just kind of doing this. And to somebody, it's just like, well, I'm doing these for this thing. Well, why? And I think the better you understand, like you said, I mean, you will just go leaps and bounds above where you would have been personally, but also, people that aren't willing to take that next step. So I just love that you keep hammering it's the fundamentals that like you just keep, the soil that you grow everything else from. So I love that. Um, from we were talking about convergence, and that's, like you said, probably one of the most common things and one of the easier things for me to talk to about a patient or a student. What's something that maybe you find yourself struggling when you're talking to a patient, or maybe it's clinician too, of, well, we are doing this a lot, but like this is hard to explain why this works this way, right? It's very easy to understand. Well, if I can turn my head this way, or this shoulder is, a contralateral pattern. But what's something you're like, man, this is just something we're doing all the time, but like from the framework of neurology, it's very hard to like make this not make sense, but like explain exactly why it's happening that way.
Yeah. That's a really good question. I think probably what is more challenging for people to grasp in the beginning is probably things like referred pain from, well, there are a couple of things that I think are challenging. So when we talk about
I'd love to
referred
get into
pain,
that one for sure.
yeah, from diaphragm, gallbladder. So basically, old school head zones. Why does that happen, and what can we do about it from a manual therapy perspective? I teach a tremendous amount of breath work, breathing exercises, which it's very interesting in the clinical field because most people, when they hear that, they go, "Yeah, that makes sense. Breathing's good." But whenever you start looking into the neurology of it, and how can I target the right cortex with a breathing pattern? Why would diaphragmatic restrictions potentially be a major player in something like shoulder pain or neck pain? Why can I've often made the assertion, if someone has neck and shoulder pain, it's ethically inappropriate to not evaluate the diaphragm. People hear stuff like that and they get upset. So I think things like referred pain that are more not only experientially a little strange for people, but they're also, I don't believe that they're very well explained in terms of the neurology when people are in the educational environment. So I think those are often overlooked in the musculoskeletal world. Interestingly enough, they're rarely overlooked in internal medicine and surgery. So you can take that for what it's worth. Another thing that I think is difficult at times for people to grasp is, especially if they come from a manual therapy background, is how much of a focus I have at this point on working just with the skin, just with the dermal layer. Most of us come from, manual therapy, mobilization, manipulation, cross-fiction massage, blah, blah, blah. And over the last probably 15 years or so, I'd say I've cut out 80% of those more intensive interventions because in many cases I can create similar or hopefully even better results working with the dermal layer, and that has been very interesting to try to explain, I think, to people why that is. So that one's a little hard to grasp. But
Can you give an example of something that maybe was a little more, I would assume, heavy-handed versus how now that maybe I don't know, lighter both in approach and actual like physical touch?
sure. So as an example, as I said, I come up from a relatively intense manual therapy background. A lot of our original instructors were Rolfers. And I studied myofascial release and in chiropractic, old school Nemo technique, and all these things that were very deep tissue oriented. So previously, probably in the late 90s, early 2000s, if someone came to me with an old knee surgery or an abdominal surgery where I felt like there was a lot of scar tissue, I would spend quite a bit of time trying to break up that scar tissue and etc. And often, I think I had some effects, but I also think it was not as regularly effective as I would have hoped. And that's very much in contrast now to how I approach the same scar. Whenever you look at the dermis as a primary predictive tool for the body, right? This is what's interacting with our environment. We're running into things, we're touching the desk, our clothes are touching us. So a lack of tactile acuity anywhere in the body is going to typically increase threat because it makes prediction more difficult. So now, as opposed to let's go in and break up scar tissue, a lot of the approach is let's actually test that scar. What is it currently able to sense? Is it lacking acuity for sharp, dull, warm, cold, vibration? So I usually start with more sensory evaluation, sensory rehabilitation. If I'm then doing any kind of hands-on therapy, I do a lot more dermal, like decompression work with my hands, similar to maybe what you would do with cupping, but with less intensity. And we do a lot of pre and post testing to say, okay, at what depth, in what direction of stimulation does the rest of the body appear to respond well to dermal level interventions? So, yeah, it's, again, my classical education was find sticky stuff, make it unsticky. And now, after a lot of years in neurology, the sticky sometimes needs to stay. There's a safety factor in that.
Yeah.
The more important thing is, does the brain perceive that area as a threat? And if it does, how can you reduce that using all the tools at your disposal? That doesn't mean that deep tissue isn't sometimes required, Graston or whatever you want to call, your instrument assisted soft tissue. Like, I still keep all those tools available. I just find I use them much less frequently.
Far more sniper an approach versus just kind of, shotgun.
Yeah. And a lot of it depends on the client's background. If you have people that are being hit and punched and run over, sometimes they don't respond to very soft therapy. So, there's a lot of history taking and lifestyle involved in all that. But I think as a practitioner, you need to have tools that run the gamut.
And that's, I always kind of find myself saying, if, there's been a big push to be very hands-off, very pain neuroscience based, that we can just be explain and educate. And it's like, if you want to work with like a high level athlete, what are you going to explain to them how to perform better? Or can you actually create better performance and, limit injury if that's our goal? But going back to scars real quick, again, like you've elucidated a lot, and other people like Steve Capobianco and, but those are some of the miracle cases where also you kick yourself. Like, I've had ones where I go 2-3 visits, and I always find I ask about surgeries a couple different ways now, and people just still like, oh, I had a guy that came in the other day. I ask hey, have you had any surgeries? No. Have you had any abdominal surgeries? No. And then I specifically always say appendix, gallbladder, hernia repair. I had my appendix out when I was 6. He literally said that the doctor was drunk. I don't know if he lived in a town of 50. This scar was horrendous. And he had right-sided low back pain or right-sided, scarred. And it was just kind of one of those like, oh, look at this. But it's just, if you've never paid attention to that, it's not always the thing, but when it is, it's like, it is. And it can be very key to the case. So I think that's just, a subset. It's a tiny subset of what you do and teach about, but it can be vital to a case.
Yeah, scars they're a big deal, right? They're a living record of a major threat. That's what I tell students. So it doesn't mean it doesn't mean the brain's currently bothered by it, but it's definitely worth testing and considering. And yes, it's unbelievable what people forget and will not tell you. So I ask about surgery, scars constantly, different versions. Have you had this? And then I look at them like, what's this? What's this? I had a guy years ago, I was teaching a class, and I was asking him if he had any injuries. We were just doing a demo. He's like, no, not really. Any scars? No. I'm like, all right. And this was in Europe, and it was cold. He had a coat on. I'm like, all right, we'll take your coat off. And he had this giant, enormous scar down his left forearm. I'm like, so nothing? He's like, oh yeah, I got harpooned. I'm like, harpoon? Now that I've not heard before. Working on a fishing boat. Anyway, yeah, people forget, and they often won't tell you. Cosmetic surgeries are the worst.
Yeah.
You really have to ask specifically.
Yeah.
And those can be really problematic. I always tell people, experientially, there's no research on this, but anecdotally, what I often find is that scars from like a scope that are arthroscopic or whatever, that are penetrating, even though the surface scar is quite small, those are often quite impactful in terms of threat. I think just because of the depth of the penetration.
Yeah. And I think there's obviously not a think. There is a big psychological component to things like plastic surgery because it's self-inflicted trauma, right? It's something you decided to do, which creates a whole another, layer cake of like what's going on here. So,
Right.
um, so you've mentioned a couple times, what you still do. So are you still in active practice? What does practice look like nowadays? Like how many people are you seeing? What type of people? How often? Things like that.
So at this point, no, I don't have an active practice. I've been teaching full time, I guess, since 2003. But I still maintain a small set of clients. Over the last 10 or 15 years, I basically kind of kept my original approach. I worked with a lot of elite athletes. So, yeah, professional athletes from a variety of sports. And then I've also worked with periodically people that are truly compromised, either from chronic pain, some CRPS cases that were very difficult. And I also spent a lot of time working with the military. So I continue to do some consulting for post-concussion, blast injury,
Yeah.
things.
Do you see that changing ever? Will you go back, or are you education for life now? Or do you ever kind of think like, man, I'd like to get back in the trenches just to see, how much I've changed as a clinician or what I could learn from going back in, being kind of,
I don't know. A part of, particularly pre-COVID, a lot of our courses were quite large, particularly in Europe. We'd have, for our advanced courses, I'd have 70, 80, 100 people per course. And that is those courses at the time were 4 days. So that is a lot of on the fly consulting for clients. So, at this point, I estimate there are probably over 1 million training or therapy sessions a year by Z-Health trainers around the world. So I actually get a lot of, I call it field feedback, what's working, what's not working. And a large part of what we do now is we're continually upgrading our curriculum. One of the things I always told people was, I build courses that I wish I'd been taught. But science is constantly evolving. So that means our courses have to constantly evolve. So I get to spend right now usually 10 to 12 hours a week just reading papers and trying to find, is there new stuff that we need to be including in the curriculum? Are there things contradictory to what we thought we knew? Stuff does pop up. So we're, constantly in this kind of refinement process. In terms of getting back into full-time, I've considered it, but it probably would be in a really specialized capacity, maybe just working with a team or something like that. I have a couple of our trainers that, they are exclusively with professional teams. We've done a lot of work in Europe with professional soccer. So now there is one of our athletes then went through our training. He retired out of the Bundesliga in Germany, I think about 4 years ago, and he now is in charge at the DBF, which is the Deutsche Bundesliga, main association. They actually created a neuroathletic division at their new academy. So it's cool because there's a lot of opportunity to see how things are interacting at the professional level. They have a lot of students coming in there. So it's also beginning to direct some research studies. So for me, I think from a progression perspective, it would be that, or, just opening up a research institute, because I really find at this point, I find the science behind it super interesting. But I always have this bent toward, okay, that's cool, but what do I do with it?
Yeah, the applied portion again. It's great to sit there and read papers all day, but does that
athlete by nature? I need to feel it.
Well, let's hit a couple of the questions that I ask everybody. So the first one is, we obviously got a good feel for what you do, why you do it in this talk, but how do you think, in particular, I would say healthcare, but conservative musculoskeletal care, how do you think that's going to change in the next 5 to 10 years? Do you see a tidal wave of anything that's going to be needed from what we arm ourselves with as clinicians, or just a totally different approach? Or, what's your general take on what's going to happen?
Well, here's what I can tell you what I would love to see. Whether it will occur, I don't know. Um, so on the conservative musculoskeletal care side, I think that the market is going to continually explode. Meaning, I think pain syndromes, whether we like it or not, are going to increase in number as a result of this kind of current, very weird 2.5 year period. We now have we have a lot of social issues, right, that are coming. And we know based on research that as all these stressors increase, we're going to see another large wave of dysfunction. We're going to see more pain issues arising. So my hope is that as a profession, the that there will be kind of this grassroots effort to help practitioners really understand modern pain neuroscience, right? Not that they have to become pain neuroscience education geeks or whatever, but they begin to truly understand that their job is threat modulation. Find out what's threatening the client's nervous system and modulate that somehow, either decrease it or increase it based off what they need. I know that at many schools that I think their curricula are improving. They are talking more about neurology. I think I see that happening. So that's a nice wave. My big issue, and I think this was interesting because I was having a conversation with my son a few weeks ago. He's in his third year of medical school. And his first rotation was in the ER. No, sorry, not ER, in ICU. So, his first month he was dealing with people who were dying. And we had this really interesting conversation about medicine, right? And just the general practice of medicine. And he said something really interesting to me, which echoes what I've said many times, which was, I think we were talking about, he had so many compromised people he was working with, but he said, it's all that I can do as a doctor to try to keep people alive. There are people far more qualified to talk to them about diet and exercise. And I thought, okay, this is from a young guy going through school, and he's starting to recognize that he's got his direction, right? Conservative musculoskeletal practitioners universally, I believe, are considered to be experts, not just in conservative musculoskeletal care, but also in exercise and all the health factors. So my hope would be that we'll see a larger blending of those, but done with respect to the professional's time. So if you're a DC, DPT, whatever, your job obviously is diagnostic and providing very targeted care. So I would love to see continual integrations of super well-trained practitioners with super well-trained coaches or trainers, more integrated practices, because ultimately, you can actually go back and look at the statistics on this. Most people who are truly sick in the United States will get about 15 minutes of actual face time per year with a healthcare practitioner. And that is just completely insufficient to give people enough information to create behavioral change. The people that are, I think, best placed to do that are health and fitness professionals. They're going to average somewhere between 100 and 150 hours of direct face-to-face interaction per year. So if we can, join these two groups together in a more intelligent way, I think it offers the highest level of ethical care that we can. So that's whether that's going to happen, I don't know, but I do think there are a lot of very smart and I think entrepreneurial people in the musculoskeletal field who can drive changes like that. I know integrated practice is already out there, but it's still from my perspective, I think it's still very minimal compared to the need.
Mm-hmm. Well, and I mean, I couldn't agree more. I researched this ad nauseum for the book that came out early this year that I wrote, and just kind of, I mean, it kind of surprised me when you dig into it. Of the biggest health burden worldwide is musculoskeletal disorders, and then if you break it down, I mean, it's obviously there's multiple factors that tie into that, but then I mean, that was the premise of my book, is that this may be one of the biggest root causes for a lot of other health things that we're dealing with is, whether that's tied up in lack of movement and actual musculoskeletal injury or pain. But what I kind of find myself saying all the time to students is, general health is getting worse and worse worldwide, not just in the US. The US for sure, we're like the beacon of unhealthy or becoming more unhealthy. But that, I think, just makes our job harder, right? The tools that we are equipped with now will be less effective in a decade, which is why I agree with you. We do need to have, a team-based triage approach where it's not just, hey, we come and do the same stuff and you got to do it more often and, longer sessions. Like, there's more aspects to health than just what we do. Even if we are applying, neuroanatomy to the patients or having improved outcomes, it's, if they're systemically unhealthy, you can do all the fancy neurologic tricks in the world. Doesn't matter, that much at all. So I think that, again, can be tough for a student or a new doctor here, because they're like, well, here's a whole nother level. And it's like, well, again, get a team around you. I think somebody needs to be at the center of that team as a quarterback so you can understand overall. But like, if you equip yourself with a team, I mean, you're going to help more people than you would ever help by yourself anyways.
Absolutely.
Well, these are really fun questions, at least to me, because I kind of think it spins people a little bit. What is something within your specific discipline that you have changed your mind on over the course of the last maybe year or two that you used to practice or used to tell people? Something you're like, man, I've completely flipped on this based on the evidence or, your own personal anecdotal experience.
Completely flipped. Anything I've completely flipped on. I will say one of the things
I would say.
I will say one of the things that I have altered the most in the last couple of years based on emerging research is some of the post-concussion work approaches. When I really first started digging into brain injury, post-TBI work, I spent a lot of time with certain visual factors, certain vestibular factors. We did focus on breathing and some metabolics, but I would often start with these kind of high order systems. Now I have, I think, a much more clear window into the level of compromise has to determine which visual vestibular interventions and the timing of all that. So we now typically include a lot more vagal nerve stimulation and aerobic exercise early on. In a very graded way. And this is a result of some super interesting research looking at TBIs and how there's some shunting of blood away from the injured areas. So really increasing their metabolic capacity with aerobic exercise and breathing has become much more foundational. So I'd say that's one of the things that I've probably changed the most based on stuff that's come out.
Very cool. And then the flip of that, what is one thing in particular, maybe two, that you are just like, I know this is the way it is. I know it's true, but there is not a body of evidence out there to support what you would do or think right now?
It's a really interesting question because we've tried very, very, very hard to eliminate that. Things that we don't
a good thing.
Let's see. Someone was just asking me something the other day, and I said I don't know. I guess if I had to choose anything, whenever we from an educational model, we spend a lot of time looking at gait mechanics, gait neurology, and I think we can make very strong arguments for why we present gait the way that we do, because we just teach this basic concept we call neurogait. That basically looks at how the brainstem interacts with the cortex to control postural stability and gait. Gait, however, is probably one of the most complex things in human neurology, which means that the simplified perspective that we use, because it's clinically relevant, you can probably make a lot of arguments that things work differently than how we present them. That doesn't make it, I don't think it makes it wrong, but I just think often whenever I'm presenting on Gait, I go, look, guys, it's way more complex, but this is from a practical level, this is what I want you to learn. So I think that's probably what I get asked about the most, is just these kind of basic patterns that we tell people to look for. And just when you actually look into gait neurology, it's exceedingly complex because it's one of the most important things that we do.
Well, now you open up Pandora's box, because this is probably the thing I'm interested in the most. I deal with a ton of runners. I work with a Gait lab out of Belgium that gathers a lot of data. So I just want your quick take on this. And then I'll chime in if I feel like I have anything to add. But do you think which I'm going to know the answer to this, should be using Gait as an objective tool? B, do you think you should be working on Gait specifically, or allow Gait to change based on other interventions?
Great. Simple answer to first question is yes, absolutely. I tell people Gait is a window into brain function. It literally will tell you more than almost anything else about how the brain and body are interacting than any other assessment. I usually tell my students, if I only had two different things I could do for an assessment, I would test the eye movements and then I would watch people move. Right. That's it. Because if you understand enough about those, you can get a very accurate picture of what's functioning well and what's not functioning well. So yes, we should absolutely be using it as an assessment. Should we cognitively attempt to improve gait? My general answer to that is no. I think there are times, if you're working with someone who's already highly skilled or someone who is extremely compromised, they're hemiplegic or whatever, that we may need to include a lot of cognitive effort into the process. If you have someone who's suffering from cognitive decline, there may be some value in like dual tasking gait activities. But in terms of actually trying to change an arm swing or a foot position or whatever, from a neurologic perspective, I think it makes far more sense to try and understand the underlying drivers of those behaviors and deal with those first and allow the body to make changes based off the changes in tone. When you look at, your typical external rotation, overpronation, lack of arm swing, there are generally very specific drivers for those deficits within the brainstem or cortical brainstem interactions. So that's been my general approach for years because, I came from the traditional, hey, postural correction, it's, get against the wall, do your million scapular retractions, stent, always be setting. And I learned that clinically, but it never made sense to me as an athlete, because as an athlete, I'm like, you're supposed to be focused externally, not internally. And now if you really dig into the motor learning research, it's very clear that external focus of attention tends to enhance movement skill. So having people constantly trying to solve gait issues, positional issues using an internal focus, while it may on the surface solve the problem, it may not enhance their movement competency, which is really what I'm interested in.
Which, when you're talking about kind of interference, right, or the lack of feedback for a variety of reasons, that's one more kind of almost like static signal, neurologically, is just to give them a conscious level thought on what should be truly one of the most inherent things to a human, right? Your gait, it's kind of like a fingerprint. So I just think it's interesting when somebody's like, well, I'm really thinking about doing this. And I'm like, I know you are. That's the problem. You're really having to think about this stuff. But I agree, there time and place for everything, and maybe it's a stopgap tool for some people for sure. But yeah, there's always something underlying that for the most part.
Right.
Um, I mean, I could literally talk to you all day. I mean, this is when I was in school, I was a neuroanatomy tutor. It's what I was interested in. Then I got exposed to your work and, just have dove in head first from the beginning. And, it's endless. I mean, it's how you apply it and what vein you apply this stuff that makes it specific to your own practice and your individual interests. But I don't know where I'm going to take my practice in the next 10 years with this. But what's next for you or Z-Health? Like, what is there anything on the horizon that you guys are new classes, new endeavors? I'm sure there are, but
Yeah, there always are. So our general curriculum is quite well developed at this point. Obviously, we've been doing this for 20 plus years. During COVID, we invested a lot of money to improve our online delivery systems. So we work with a studio here locally. So we now have everything professionally produced, and the online educational environment is there. But I guess in August, we finally released something that I've been dreaming about for 8 years, which is what I call a brain-based practitioner's guide. We're doing it as a membership, but basically what these are, they're like mini certifications around specific complaints. So they're 5 to 6 hour studio presentations. Our first one was on headache. Next, we're doing shoulder. We just filmed knee last week. So these are very fun because well, to put it in perspective, 8 years ago, I sat down and I wrote out a shot list and a book plan for what I called the Pain Relief Encyclopedia. And it was originally intended to be something for the general public because people were constantly asking me about, hey, can you make products for the general public? And I sat on it for a long time because something didn't feel to me intuitively, it didn't feel correct to do it that way. So over the course of the pandemic, as we were taking care of all the studio shoots, it just really started to occur to me, this is something that I still want to do, but I want to make it for professionals. So right now we have 12 or 13 more shoots planned over the next year and a half. So we're just gonna be working our way through the body, dealing with specific issues that often crop up in practice. And that's been I'm glad that it took this long because I actually think now the concepts are far more interesting because now you can actually look up, all right, let's talk about brain imaging and low back pain. Let's talk about the anterior interposed nucleus and the cerebellum related to shoulder pain. We can actually find data that is useful. So I'm glad it's taken this long, and I think it's going to be that's going to be an interesting process for people who are interested in this level of neuroanatomy and neuroapplication.
I think
so. That's our big project right now.
I think that's amazing. And I know you have foundational courses, right, that are building the principles around this, but also I think that those types of courses will be great entry points, even though they're kind of technically, towards the end, if you think about it conceptually, but like it could show people like, we do this, and then the understanding, it's like, well, if you want to go deeper, you actually go back to the principles. Is that how it's kind of designed?
That's how it's set up. Yeah. So basically the way we're filming it, we make the assumption that people have at least some background, but we start off with, look, these are the stats. Here's your basic anatomy. These are the areas we're going to be focusing on. And if we then demonstrate things that are found in our curriculum, we'll say, look, if you've been to these courses, you already know how to do this, but let's at least give you an example. So we're trying to make it a product that anyone who's a professional can get a lot out of. Obviously, if you have a deeper level of understanding, you'll get more out of it, but that's true of all education.
Mm-hmm.
You never hear the same information twice because you're different. So I think it's going to be a really interesting introduction for a lot of people. And the original curriculum as it's developed is very broad. And this is me not being a marketing wizard because I was like, this is the stuff people need to learn. It's not exactly how people want it presented, in that they are, most people come to this going, I want to know about headaches, or tell me about neurology of the knee. And I'm like, the knee doesn't work by itself. So that's been an interesting marketing challenge. So I'm hoping this, particularly for people who are not true early adopters, but are, they've been waiting around to see how this whole neuroscience thing is going to go for a decade, that maybe this will be a nice entryway for them into some
I
of the concepts.
I think it's great, and I mean, you're also appeasing the market, right? I mean, I educate far less than you, but every time you do, and you're trying to teach a framework, people still want the pieces, right? They, well, how do you do it? And it's
Exactly what to do.
you're trying to teach them how to fish, but they're like, well, yeah, I get it, but so I think you're doing both now, right? You have the framework, and I mean a big, broad framework, and then these specifics will just be amazing. So I mean, I'll definitely dig into it for sure, and I will be passing those on to our interns and preceptors to give them a good jumping off, and then say, hey, we have all this available. Like, go do these when you feel like you're ready to. So I think that's great.
Good to hear.
Well, again, I cannot thank you enough for coming on here. I know you're a super busy guy, and like I said, I've kind of been a fanboy for since I got out of school, and I think every clinician, regardless of profession, PT, chiro, strength conditioning coach, whatever it is, should be exposed to this. And then it's up to you to determine how much you're going to use. But like you said, you're either using it on accident or on purpose. So I know which one I would pick. Um, so any last morsels of advice or parting words for anybody that's looking to dive into this, or that's, brand new to the game, how to start, how to get into this?
Yeah. Well, first, before that, thank you very much for the invitation. It's been very nice talking with you. Yeah, if you're new to this, you're new to the profession. I think most people that get into the helping professions, if we can call it that, especially in the modern world, are not doing it just to make a good living. They actually are driven by a really strong ethical desire to make people's lives better. And my first piece of advice typically is hold on to that, because that will direct your studies. That will direct you into wanting to do better for people. I hated going home feeling incompetent. It was one of the worst feelings in the world to me. Not because I had an ego attachment to being right, but because I felt I had an ethical responsibility to help this person who was trusting me.
Mm-hmm.
And that has been, for me, probably the biggest driver for my entire career. Not, I'm like everybody. I have bills to pay, and I wanted a successful business. But and what drove, I think, a lot of this was I wanted to be a better clinician. So whenever you're presented with options, I think the best piece of advice I can give you is follow your ethics. Like, if you feel like this will help you be a better clinician, then do it. Invest the time, invest the money, invest the energy. The only caveat to that is, especially when you're new to all this, I guess, be a little bit careful and trust your intuition. When things sound too good to be true, they are. I know that's a horribly cliched saying, but it exists for a reason. So the parameters I think that we have to embrace really should be driven by, what do we know about emerging science? All right. We are, yes, practice is an art, but it has to be science informed. So if there is not a super clear physiologic rationale for what anyone is teaching, either try to get that from the instructor or figure it out on your own. If you have a physiologic rationale, what I can tell you is it will vastly increase your confidence with application. If you are learning something that you literally can't explain to anyone, there will always be a little part of your brain that's like, I'm uncomfortable with this, and I probably shouldn't be doing it. And that will impact your relationship with your patient.
Mm-hmm.
So I have always felt very strongly that you need to be very clear, and have a clear rationale that you would be comfortable explaining to your parents, to your patients, and to fellow professionals, that they would all go, okay, yeah, that makes sense. And then you can feel very confident with what you're providing.
Love it. So be led by your ethics and seek understanding. I mean, if we if we literally just any project or endeavor in life jumped into it with that, I think you'd have a pretty good outcome versus being led by, something else extraneous like income purely, or, whatever else it is, ego. So I think that's amazing to end on. And I'll thank you one more time. And I will also be linking to, Z-Health social media, your guys' website. I probably, this is me just self-admitting, I probably share more of your stuff than anybody, because I'm like, oh, that's a very good quote. That's a very good quote. I love it. Cool. But it is always really good stuff. So if you want a good social media follow, just look at Z-Health, and it's always making me think about, oh yeah, that does make sense, or oh, I forgot about that, or I've got to look into this. So I'll definitely link to that for everybody. But I couldn't encourage, and I have numerous times. I mean, we've got a doctor that's been with us for about 3 years now, and when he came in, I still remember he was shadowing an exam, and I did an exam, and we did something, and, I couldn't even tell you what it was. And he's like, what was that? And I was like, what's this? And like, he is just dove in like head first. And he's just like, there's so much stuff I don't understand. I was like, that's kind of the beauty and the scary part too, that like you said, I go home with that same feeling. If I feel incompetent, I can't. Like, it's not ego driven. It is literally, I signed up for this job, and if I was a lion tamer and I was incompetent, the risk is going to be pretty high, not in my favor. I don't have that risk reward scenario here, but it's for the patient. It could be a life-changing event that I could help them massively if I'm armed or equipped with the right knowledge and application. So again, go look up anything that Dr. Eric Cobb's done. Z-Health, fantastic stuff. And again, thanks for being on the show.
Thank you so much, man. Take care.
Have a great day.
You too.
Here you go.